Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar session. Today's topic is mental health issues among PLHIV, and the speaker is Dr. Maithili Umte. Dr. Maithili Umte, ma'am, is the Associate Professor with the Department of Psychiatry at GGMC and JJ Hospital, Mumbai. She has extensive experience of working with PLHIV with psychiatric and psychological issues. She has published many papers in international and national journals. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Ms. Shweta. I think we should start with our session today. Today we are talking about mental health issues amongst persons living with HIV. So what are the objectives? What are the topics we'll be covering today? Mainly, we'll be covering the burden of all the mental health disorders. The mental health issues or the associated disorders which are majorly seen in PLHIV, that is anxiety, mood, psychotic disorders, hand and substance use disorders. Then we'll be learning about a very important scale called as the PHQ-9, which I'll be describing later in the presentation. Then the mental health programs, both at the national level and the district level. And I'll be discussing in the end about the role of ART centers. So what is health? Health is a state of complete physical, mental, and social well-being. And it's not merely the absence of a disease or infirmity. When we look at mental health, we talk about mental health as a state of mental well-being, which will enable a person to cope with the stresses of life, realize their abilities, learn well, work well, and contribute to their community. Whereas in case of mental illnesses, we will see a clinically significant disturbance in an individual's cognition, emotional regulation, or behavior. So let's look at the burden of mental disorders. If we look at the global statistics, the last known is say in 2019, where it is known that 1 in every 8 people, that is a worldwide population, we are talking about a whopping 970 million people, they are living with a mental disorder, with the most common being anxiety and depressive disorders. If you look up at the stats, you'll see anxiety and depression tops the list. That is at 301 million and 280 million respectively. If you look up, you'll also see children and adolescents also have a significant proportion in both anxiety and depressive disorders. Then other common disorders seen is bipolar disorder, 40 million, schizophrenia, eating disorders, and disruptive and dissocial disorders. Now let's look at the Indian perspective. There have been various community-based epidemiological studies which have been done in India, and they have reported a prevalence of mental health conditions in children and adolescents between 6 to 12%. There was a national mental health survey which was done recently. It showed a prevalence of 7.3% in children and adolescents. And it estimates that overall 8 to 13% of children need mental health services. So now let's look at the picture for PLHIVs. As we know, they are prone to psychological ailments due to HIV per se, as well as they have a problem related to opinions and experiences regarding HIV in their surroundings. They face multiple types of psychological issues like depression, anxiety, internalized stigma. So overall, we see mental health issues are common. Also, we see that in children and adolescents, as compared to general population, mental health issues are higher. So as you can see, is the special population which bears the greater brunt. That is both children, adolescents, and women. Like if you compare them with other people with PLHIVs or even with the lay population, the percentage of mental health issues is much higher. So again, if we have a look of which are the associated disorders that we just spoke about some time back, along with the anxiety, depression, mood disorders, psychotic disorders, and that is HIV associated neurocognitive disorders, if we see there is a significant proportion of also substance use disorders. Often around 40 to 74% of cases could be currently using or in the recent past have used any substance and not just nicotine. Even sleep disorders So let's go one by one. So I'll go to the most common, that is the anxiety disorder. Anxiety, what is anxiety? Anxiety is an emotional response of excessive fear to a real, imagined, or perceived threat or anticipation of a future threat. So sometimes people are anxious about something which is really happening, like say an exam, a financial issue, or it could be those what if fears, what if aisa hua to, or sometimes it could be about a future problem, that what in future something happens. So here you see lifetime prevalence in the general population is 18%. And if you see in PLHIVs, it jumps up to 20 to 35%. So which are the common disorders that which are seen in PLHIVs? So if we see here, one of the common ones is GAD, that is generalized anxiety disorder. As the name suggests, the anxiety is more generalized. It's not just related to a particular stressor. So the excessive anxiety and worry could be about a number of events or activities. And the person will say that they find it very difficult to control. Now, this is different from a person who is undergoing adjustment issues. A person undergoing adjustment issues will have anxiety regarding that particular thing. But in GAD, it would be more generalized. Then the other anxiety disorder seen as panic disorder, where people recurrently have unexpected panic attacks. So these patients are more likely to be seen in emergency services, in casualties. In on history, you will say they'll have at least one panic attack. And one of the predominant feature in panic disorder is apprehension about future attacks. So they that one episode of panic or the many episodes of panic trigger like a vicious cycle where a person is afraid that what if I get that episode again? And the person indulges in a lot of avoidance behaviors to avoid that. So sometimes we also see in clinical practice a case of panic disorder do not have any active panic symptoms, but that is only because they are actively associated with avoidance behavior. Say a person who has panic because of, say, using closed spaces. So they would rather climb stairs but avoid using a lift. So invariably, they may not suffer panic attacks, but the avoidance behaviors are high. Then one of the other common anxiety disorders seen is social anxiety disorder, where, as the word suggests, it's about social situations. So a person feels anxious when they feel that they'll be facing a social situation where there are many people. So they'll be feeling very awkward or conscious in a public space, or especially in when they are talking with somebody in a higher or a superior position. There they would rather fear a negative evaluation and experience a lot of anxiety. Then one of a common panic or anxiety provoking symptom is agoraphobia, where a person will have marked fear or anxiety about having a panic attack, like in a specific, like say being in an open crowd or when being outside the home alone. So typically you will see they will go around with someone and they will never go alone. They will always insist somebody to come with them. They would avoid situations where they would be alone. And the last but not the least is specific phobia, which actually, if you're going to see, is very common. Most of the people have some or the other specific phobia. It could be of heights, it could be of snakes, it could be of lizards. So it's a specific, a particular thing, trigger, which makes people anxious. Now I'll also talk about adjustment disorder to diagnosis. This I've included here because invariably this is associated with a lot of anxiety. That is the first time a person is diagnosed. We often see a range of emotions, right from shock, denial, or blaming, or feeling very guilty. We often see that sometimes people take a long time adjusting to their diagnosis. So it was always seen that adjustment disorders occur within the first 3 months of diagnosis. And since it's an adjustment issue, they generally do not last more than 6 months. Anything lasting more than 6 months could point to a more core anxiety or a depressive disorder. So we see it in 6 types. So one is the one associated with depressed mood. So typically they'll feel low, they'll feel tearful, feel helpless or hopeless, or feel suicidal. Or it could be associated with anxiety. So a person will feel very anxious, nervous, have palpitations. Or it could be a mixed picture of both anxiety and depression. Sometimes we also see cases where there are disturbances of conduct. So typically they will present with more of anger, aggression. They will get irritated. They'll break things. They will get into reckless fights. There'll be a lot of anger at the base of it. So more of a little antisocial behavior which might come up. And again, there could be a mixed, like both emotions as well as the conduct issues might be together. And the sixth type is unspecified, where it is doesn't fit of the any of the above and some symptoms of the above. So now, how do we manage these anxiety disorders? One and first and foremost is most of them require psychotherapy with supportive counseling. We require a lot of behavioral techniques in them as well. Often long-term psychotherapies are very useful in these cases, especially the ones which are recommended are interpersonal psychotherapy, interpersonal group psychotherapy, group support psychotherapy, or CBT. Uh, if need be, they can also be treated with medications. One of the preferred drugs are short-acting benzodiazepines. So you could have something like a lorazepam or a alprazolam, or a shorter-acting benzodiazepine like a clonazepam. Generally, it is always a rule of thumb that for anxiety disorders, the use of benzodiazepine should be brief and should not last more than 2 to 3 weeks. And the mainstay of treatment to the right, as you can see, is antidepressants. That is because we do not want people to develop dependence on the benzodiazepine. So they should be given as a cover till by the time the antidepressants act. Since most of the antidepressants take around 6 weeks, 2 to 6 weeks to act, so it could be used as a cover till the effects are seen. So what are the typical antidepressants that we prefer? One is the tricyclics, very common. I think it must be used in many centers, and availability and cost-wise, cost-effective drugs are imipramine and amitriptyline. Then we have a lot of good SSRIs, which have very low drug-drug interactions, are comparatively safe, can be used safely even in older individuals. Those are fluoxetine, paroxetine, sertraline. Or we also have SNRIs like venlafaxine, which are very useful molecules. So now let's go to mood disorders. So mood disorders mainly seen are depression. I'm sure most of you all must have seen depression cases in your ART centers. The other mood disorder, that is the other end, that is the bipolar affective disorder. I'll cover that later. First, let's come to depression. Now, if you see mood disorders, anxiety is extremely common. Like 9 out of 10 patients of depression will experience anxiety symptoms sometime or the other. Sometimes, rarely, you'll also see that the patient never complains, is the family member who will complain कि अभी बहुत चुप चुप रहता है या ज्यादा बात ही नहीं करता है, बोलता है छोड़ो ये इलाज करके क्या फायदा, अभी कुछ नहीं होने वाला है. So sometimes you might get a situation when the family members will complain, the patient will not. Sometimes you might get a melancholic features, like the person might have anhedonia, will not be able to experience, not just not experience pleasure, sometimes even say they can't experience any emotions. Typically they might have early morning awakening or suffer loss of weight, they might experience a lot of guilt. Some cases may also experience catatonic features. Catatonic features like they'll be very withdrawn, negativistic, have psychomotor retardation, the affect might be blunted, like the face might look very mask-like. In some cases, severe cases, psychotic features also can be seen where the person can hear voices, feeling that people are making fun of them. So what are the classical symptoms that we see in depression? If you see, again, in depression, the prevalence is much higher than the general population. If you see, 40% as compared to 4 to 8% in the general population. Now, there are two types of depressive symptoms. One is the affective. Affective means the mood symptoms. So typically they will say, अच्छा नहीं लगता है, low लगता है, उदास लगता है, मन एकदम कड़वा खट्टा लगता है. Or they might say loss of interest, कुछ भी चीज में interest नहीं लगता है, मन ही नहीं लगता है किसमें. Or they might experience feelings of guilt or worthlessness, और फील हेल्पलेस और होपलेस कि अभी आगे कुछ होने वाला ही नहीं है, छोड़ो ना, क्या करना है आगे. और दे माइट ऑल्सो फील सुइसाइडल, विच कुड बी बोथ active or passive. Active matlab the person might feel that it is better that they die, they do something to end their life. Whereas passive death wish is more like कि भगवान उठा ले, अभी और जिंदगी में रखा क्या है, where the person just hopes to die but doesn't have any active wish to do so. The other depressive symptoms we see are the somatic symptoms, that is loss of weight, appetite, disturbances in sleep. Classically, you will see early morning, getting up early morning. There could be agitation or retardation, fatigue, and loss of concentration. One more of the affective symptom I would specifically like to mention is a diurnal variation of mood. So people who are depressed will classically say that they feel worse in the morning and it gets better as the day progresses. I'm telling you this specifically because sometimes there's an interlap. Like persons suffering from HIV could also have some other disorders or illnesses which might mask the picture of depression. Like, they could also feel, have loss of weight, have problems in sleep, or have a lot of fatigue or concentration. But if you see the affective symptoms, it's what differentiates the fatigue from depression. And classically, you will see people who get tired or who are experiencing fatigue will say that it gets worse as the day progresses. Whereas in depression, you will see the opposite. They will always complain that they just don't feel like getting up in the morning. They just keep lying down in bed and they don't feel like doing anything. So that is one classical symptom of depression. Now, if we look at the cycle between depression and HIV, so it's a vicious cycle. Like it is said that depression itself could be a risk factor for HIV because a person who is depressed could have poor adherence to ART, predominantly because they might just feel hopeless and feel there is no sense in going ahead and doing all this, taking the medications. It could impact their behavior. Because a person is depressed, he might drink more alcohol, use more drugs, or might indulge in more self-destructive behaviors, or might have poor partner choices. This makes the person more susceptible to contracting HIV. In contrast, PLHIVs themselves could have conditions which can lead to depression. One which is known is that there could be a direct injury to subcortical areas in the brain. So here neuropathological changes might happen. One of the common trigger, as all of you all must have experienced for depression, must be discovery, that first time the diagnosis comes. Or at every benchmark, like, whenever the illness progresses or whenever there is a major worsening, if there is any chronic stress, if there is any worsening of social isolation, they often feel demoralized. And as you know, there are a lot of stigma, there is loss of support systems, and the added pressures due to a lot of secrecy that they have to maintain. Sometimes they could lack confidence. And very often than not, it is also seen that ARTs themselves can cause a depression like symptom. So why is it important to identify and treat depression, and why I'm emphasizing depression more than any other disorders? That is because depression itself is one of the top 3 disabling illness which has a long course and leads to poor quality of life, has multiple relapses, and depression directly has an impact on treatment adherence. So a person who is depressed is more likely to default on ART, more likely to indulge in high risk behaviors, and have higher risk of suicide, higher risk of morbidity and mortality. So how do we identify this depression? One of the key factors is that the symptom should be for minimum of 2 weeks. And it should cause some change in their functioning. It should cause some change in their day-to-day life. And look at these core 2 symptoms. These are the symptoms you should ask for a person who's depressed. One, if sadness of mood is pervasive. See, pervasive is an important term here. Like say anything, like suppose today I had my day, something went wrong, somebody shouted at me, I could be feeling sad. Today one child is going to school and he did badly in an exam, he could be feeling sad. The core theme here is pervasive. That is, for most part of the day, the person will feel sad. That is what differentiates depression from day-to-day mood changes that generally are seen in the population. The second symptom that should be seen is decreased interest in pleasurable activities. So they will say whatever they like, their hobbies, they will say they will just not feel like doing it. They will say कि दिन निकालना है इसलिए या जिम्मेदारी है इसलिए कर रहे हैं, मन नहीं करता है, जो चीजें पहले खाना बनाने को मन करता है अभी करता नहीं है, काम में कुछ मन नहीं करता है. So basically they will lose interest in things which they enjoyed or which were pleasurable before. And any of the 5 symptoms apart from this should be available. That is changes in weight, changes in sleep pattern, psychomotor retardation, fatigue, feeling worthless or feeling guilty, decreased concentration, thoughts of death, and poor self-esteem. So now here we'll go to one case. So let's look at this case study 1. There is this 46-year-old man, PLHIV, who has been on TLD since past 3 years. His CD4 count is 750 cells per millimeter cube, and his viral load is uh, very low. Now, with the death of his mother 3 months ago, he complained of persistent low mood, frequent anger episodes, insomnia, with early morning awakening, and passive thoughts of dying. Now, I would like to ask you all, how would you manage this case? You all can put in the questions in the question box, your answers.
Yes, ma'am. Participants are requested to please post their questions in the chat box. Ma'am, can you please repeat the question?
Yes. The question will be, how will you manage this case? A person who is visiting the ART center. He's a 46-year-old man on TLD since past 3 years. The CD4 counts are 750. And his recent stressor, that his mother expired 3 months back. And he's complaining of sadness of mood, irritability, early morning awakening, and passive death wish. So these are the treatment choices. What would be preferred?
Ma'am, we have a response in the chat box. We
Ha.
have few responses coming in the chat box. One is due to suicidal feelings,
Hmm.
psychiatric referral can be done, is
Yes.
needed. Then there is counseling and antidepressants,
Yes. Very,
psychotherapy,
very good. Yes.
all of these, counseling.
Yes. Yes. I think people are on the right track. It is perfect what you all are saying. See, now this person has already spoken about passive death wish. He's not given an active suicidal thought. But it is important that since he has told this, we assess if there is a risk of suicide. So, what could be asked if there is any past history when the person has attempted, or currently does he intend to do so, or does he have any plan? Like typically people say, मर जाने को मन करता है. तो if you ask, they might say, लगता है गाड़ी के सामने चला जाऊं. But you can ask them what have they thought. Okay. The other thing could be assessed would be his level of anxiety. His depression could be assessed. See, in this case, there is a mother's death 3 months back. So grief or bereavement is quite likely. But then if you see the intensity of the depression is pretty high. It is more consistent with a major depressive episode than just a grief. So of course, this person comes to you, you do a suicide risk assessment, you assess for depression. Please do counsel him that time to adhere to ART, because it's very common. Depressed people feel hopeless and are very likely to become non-adherent. Then, of course, because since the person is having severe depressive symptoms and is having a passive death wish, you can refer to a psychiatrist. He will require antidepressant medications as we described. Tricyclics are there, SSRIs are there, SNRIs are there. So the person, always remember, once medications are started, should be taken up to at least 6 to 9 months. And the patient, whenever they are following up with you, of course, you can refer to a psychiatrist, but very often they'll be coming back to y'all. So y'all can also monitor for if there are any side effects. Every 2 weeks initially you can see. And in the normally the side effects are seen in the first 2 to 3 months only. Then the patient should regularly follow up and can be assessed for his depressive symptoms. So yes. Yes, coming back to depression, here I am talking about specific age groups where the symptoms of depression might be a little different. Like say children, like those 12 and below, you might not get typical symptoms of sadness of mood. Rather, you would see that the child gets very reluctant to go to school. At the time of going to school, they will complain, they will cry, they will cling on to parents, they will not let their parents go for work. Their grades might drop, so the academic performance will go down, or they might just become withdrawn and not play with other friends, appear very morose and quiet. They might not go out with friends. Inversely, they might also become very irritable and rather than complaining of sadness. So this is one clinical picture that you should keep in mind in terms of children. Now, adolescents again could have a little different picture Of course, they could also have problems typically in academics, that could be a sudden drop. But in adolescent, very often we see acting out. So, they would rather take part in more risk-taking behaviors. They would use more drugs, or there could be truancy. So they might start bunking school or college. They might run away from home, indulge in antisocial behavior, hang out with the wrong kind of friends, or they may even indulge in sexual promiscuity, and they could be having a lot of anger outbursts. Now I'm specifying also about old age, because old age depression is often underdiagnosed. Because old age, very often we see that patients do not complain of depression, rather they would rather become more quiet. As a result of ageism, these symptoms might be dismissed because a person is older. So, a person becoming quieter, or, doing less activities might be like, they are becoming older and get tired. However, why I'm talking about old age more, I'm specifying because the chances of completed suicide are much higher in old age. Now, remember, it's always the youngsters who attempt more, but the completers are, the proportion is much higher in old age, that they use more fatal means to commit suicide. So going to the other disorders, we have bipolar affective disorder, which again, if you see, there is a tenfold higher risk amongst PLHIVs. Prevalence is up to 4.3%. So typical symptoms that you see in mania, that is inflated self-esteem, grandiosity, decreased need for sleep, increased talkativeness, racing thoughts, or they could indulge in a lot of risky behaviors. Now, this becomes very tricky for PLHIVs because it causes a vicious cycle. I mean, this itself could be a risk factor for developing HIV. And for PLHIVs, the risky behaviors, including unprotected sexual contacts or sexual indiscretions, can lead to a further propagation of the HIV cycle. The other pole of the bipolar is the depression, and the bipolar depression is almost same as you see in the unipolar depression that I explained before. So how do we manage the bipolar mood disorder? For the manic phase, very often we use IV antipsychotics, that is, IM antipsychotics. Very often we use haloperidol or olanzapine. Our options are available. Benzodiazepines like lorazepam and diazepam are often used for behavioral control. Sometimes when the patient is extremely agitated, that time rapid neuroleptization means they are given antipsychotics one behind the other to gain control over their behavior. So common molecules use are haloperidol or zuclopenthixol, both of which are used IM. Haloperidol is often given along with promethazine in the same syringe to avoid any extrapyramidal reaction. Following this injection, 8 or 12 hourly injections or oral doses can be given. Antipsychotics could be typical, like say trifluperazine, haloperidol, or atypical ones like olanzapine, quetiapine, ziprasidone, or risperidone. Benzodiazepines, we prefer longer acting like clonazepam. Now, what is very important is in bipolar, they respond very well to medications, but they require maintenance to prevent further episodes. Often psychotherapy helps. Now, for treatment of bipolar depression goes a little similar to unipolar depression, but in bipolar depression, we prefer giving mood stabilizers, that is divalproex, carbamazepine, oxcarbazepine, to prevent further mood episodes. Now, going to psychotic disorders. Again, you see the prevalence of psychosis is higher than the general population. The clinical symptoms seen are mainly hallucinations, which could be auditory, visual, or tactile. They could be having delusions, affective symptoms. There could be some cognitive impairment and behavioral disturbances. Here, only thing you need to keep in mind among psychotic disorders in PLHIVs, we generally prefer to treat with atypicals because there is a higher chance of extrapyramidal side effects with typical as compared to the general population. Also, one more component is that sometimes we can see substance-induced psychosis. Especially there are some drugs like, cannabis, methamphetamine, cocaine, hallucinogens. They are more likely to precipitate psychotic disorders in PLHIVs. One of the other issues seen is delirium. Delirium is important because very often it can be mistaken with depression or psychosis. So what happens? Delirium, there are two types. The person predominantly becomes disoriented in time, place, or person. And these could be of two types, hypoactive or hyperactive. In hypoactive, the person appears very dull, lethargic. And this is the phase where it could be mistaken with depression. And the hyperactive ones, the one which could be hallucinating or could be having picking behaviors or could be muttering, they are very often mistaken with psychosis. So here, the differentiating factor is the orientation. And that stays the key. And why it is important to differentiate? Because delirium points to an underlying medical condition. And especially in PLHIVs, you should consider if there is some drug-drug interaction or it could be some CNS infection which is developing and which is giving rise to delirium. So find out the underlying cause whenever delirium is seen. For as far as treatment goes, reorientation therapies work well. So typically, as we see, like, ICU psychosis, that is in a closed space, they are more likely to get confused and hallucinate. So it is important for them to have windows or from where the stimuli from the environment can be seen. It's better to have bigger clocks where the person can see the time, calendars. You should maintain a diurnal variation. So say a person who's admitted in the hospital. So it should be important that the person realizes it's day or night. And in case of behavioral issues, a low dose atypical antipsychotic is very useful. Sometimes a low dose high potency antipsychotic like haloperidol, a very small doses could be given. Now the next disorder, HIV associated neurocognitive disorder. Now, there is a spectrum of cognitive, motor, and mood problems which are seen together, and they are collectively known as HAND. There have been multiple names which have been used so far for this. That is HIV associated dementia, HIV encephalopathy, HIV AIDS dementia complex, HIV associated neurocognitive disorder. So there are three categories. The milder one, the asymptomatic neurocognitive impairment, the medium, the mild neurocognitive disorder, and the more severe one, that is the HIV associated dementia. Now, these also can be acute, chronic, mild, or severe, or debilitating. And if you see, the milder ones are more prevalent, like 30%, and the more severe is less common, 2 to 8%. So, how do we identify? How do we classify? As you see, the first one, the asymptomatic one, the one which is common, 30%, their activities of daily living, there is hardly any interference. And the cognitive level is only one standard deviation below the mean. Whereas the medium one, that is up to 20% of cases, what we see, there is a mild interference in daily activity. So they might make mistakes in work. So this is where you will start noticing changes. But here, the cognitive level is almost similar to this, that is one standard deviation below the normative population. Whereas the less common but more severe HIV-associated dementia, there may be a marked interference in activities of daily living. So they'll keep forgetting where they kept their things. As it gets progressive, they might find it difficult to button their clothes or wear clothes shabbily or find it difficulty to do their daily tasks. In this case, the cognitive level is at least 2 standard deviations below the normative population. So what are the predictors? Where do we see it more common? Whenever there has been a CNS disease, if it is a long duration HIV infection, any concomitant drug and alcohol use, hepatitis C infections, and it is seen more when CD4 counts decline below 350 and the viral load is high. So what is the mainstay of treatment? The mainstay of treatment really is ART. If the counts are kept well, the patients can improve, except in case of the severe, the HIV associated dementia, where the symptoms could be more prolonged. In this case, diagnosis is mainly done by neuroimaging, and there are neuropsychological tests like we do BG or neurocognitive battery to see for the cognitive deficits. What are the treatment? Memantine, selegiline, bupropion, SSRI, atomoxetine, modafinil, and if indicated, antipsychotics. Now coming to substance use disorders. Now substance use disorders similar to depression both has a very complex relationship with HIV. It itself can be a vector for spread due to impulsive or unsafe sex. A lot of injection drug users could contract the infection. Also using other drugs, relapses, that itself can cause HIV. And in case of HIV, you also see a lot of pro-inflammatory changes, that is cytokines and changes in the neural reward circuitry. This is an important topic because we often see poorer health outcomes in cases who are in the past or especially currently are using substances. They are more likely to be non-adherent to ARTs and more likely to suffer other comorbid psychiatric disorders and cognitive changes. Uh, Concomitant use of drugs along with the infections, and if there is a comorbid psychiatric diagnosis, this leads to a triple diagnosis, which makes it have a poorer outcome. So what should be a goal of treatment? One should be to reduce and stop the drug use and reduce the high risk behaviors. For people who have been recently using drugs, detoxification is often important. For persons using opioid for chronic use, a methadone maintenance program referral might be useful, and substitution therapy might really help. Other treatments would be treat the comorbid conditions, then act on the adherence, counsel them about adherence, and psychotherapies like CBT, social support or support group model, motivational enhancement therapy to improve their motivation to quit drugs, or directly observed therapy are helpful. An integrated treatment is the right approach to treat these cases. Now let's move on to drug-drug interactions. Now there are no drug-drug interactions between NRTIs, NNRTIs, or integrase inhibitors with amitriptyline and fluoxetine. You can increase the drug levels and no adjustment of amitriptyline or fluoxetine is required. They do not affect the ARV levels. Okay, so certain medications can be given, but only thing you have to be careful with the molecule amitriptyline and other tricyclics because they can prolong the QT interval. So cases where you're expecting this, you should do it with caution and you should do ECG monitoring. Now let's look at some of the common ART-induced psychiatric side effects, that is efavirenz, you see depression, dizziness, suicidal ideas, psychosis, or say in doravirin, there could be dizziness, confusion, suicidality, or zidovudin could be mania, psychosis, or in raltegravir, that could be insomnia, depression, or there could be mania. On other molecules is interferon, also you could see some changes. Now, many of these molecules have been phased out from the National Health Program. Now, coming to one of the very important topic, that is PHQ-9. This is a very useful tool, and all persons living with HIV should receive basic screening for depression before initiating ART and every 6 monthly. And the two questions that I had mentioned during depression are the key questions which are asked. That is, during the past 2 weeks, have you often been bothered by feeling down, depressed, or hopeless? Second, during the past 2 weeks, have you been bothered by little interest or pleasure in doing things? If an answer of either of the two is yes, okay, they should undergo thorough screening for depression using the PHQ-9. So what are the questions? If you see, kindly read through the questions. That is little interest or pleasure in doing things. Second is the sadness of mood. So feeling down, low, depressed, or hopeless. Third would be problems with sleep, either trouble falling asleep, staying asleep, or sleeping too much. Fourth could be the lethargy, that is feeling tired. Fifth could be poor appetite or overeating. Sixth could be feeling bad about yourself, feeling you are a failure, like feeling worthless. Seventh could be the concentration difficulties. Eighth could be psychomotor retardation. So that is like moving or speaking slowly, or being the other one, psychomotor agitation, being fidgety or restless. And ninth could be the suicidal ideas or death wishes, feeling that you are better off dead. Now, these are rated from a 0, that is not at all experiencing, to 1 for experiencing this on several days, 2 for more than half the days, and 3 would be for nearly every day. So these are a set of 9 questions, which are the 4 key elements of depression which we ask. And based on that, we get a score. So a score 4 or less, depression is very unlikely. For 5 and 9, mild depression could be there. So in which case, supportive counseling, monitoring, and substitution of the ARV if required. For 10 to 14 is moderate, 15 to 19 is moderate to severe, and 10 to 27 is severe. In this case, you provide supportive counseling and substitute the molecule if EFV is going on, and it can be referred to a psychiatrist for medications. So now we come on to the case study 2, which will be dealing with the PHQ-9. So there is this 35-year-old lady diagnosed with HIV 2 years back. She is on TLD regimen. She had financial problems. Her viral load is suppressed, which was done 4 months back. She presented to the ART center. Now the counselor has applied the PHQ-9 scale and the responses are as below. Feeling down and depressed on most days, poor appetite and feeling tired on more than half the days, trouble in sleeping on several days, loss of concentration on all days and restless on several days, and thoughts of dying on all days. So the question is, what's the PHQ-9 score? And second, what is the most likely diagnosis? Can you all please go through this and answer in the chat box? Are we getting any answers? Chat box. Yes, answer.
Previous slide on score, ma'am. Yeah, we are getting
yes,
some
somebody's giving
responses.
18.
Yes.
Yes. 18. Yes. Yes. If you see, now let's try to score it again. Okay. Now the first symptom is feeling down and depressed on almost all days. Now almost all days, remember, is 3, right? Let's go to the next one. Almost all days is 3. More than half the days is 2. And several days is 1. And none at all is 0. Okay. Yes. So on all days, you get a score of 3. So trouble in sleeping, loss of concentration, thoughts of dying, those all come to 3. More than half the days, the lady said poor appetite and feeling tired. So that will come as 2. And several days she felt restless. That came as 1. So the score came as 18. Yes. So it's most likely to be moderate or severe depression. So yes, that person was very close. The last answer we got as 18. Yes, it is 15. So what do? We provide, as we discussed, for moderate and severe depressions, we provide supportive counseling messages through counselor. If the person is on EFV, then the molecule could be replaced, and last could be refer to a psychiatrist for starting of medication. Okay, we'll go to the next slide. Yes. So what are the key supportive messages? One of the important component is psychosocial support. That is, you can explain about the depression, assure that it can be managed. The feeling of hopelessness, worthlessness, negative emotions are a part of depression and they will improve, that there is a light at the end of the tunnel. You inform on the course of the counseling. It's very important to identify a supportive family member and involve them. And if possible, involve peers and community support groups. For self-management skills, the ART should be continued. Like in general health, they should get good sleep, physical activity should be resumed. And to reduce stress, they could identify the stress points, discuss problem-solving techniques, suggest any stress management techniques, suggest meditation or relaxation techniques. So in general treatment, adherence, regular conversations, discussing drug use, restricting screen time. Yes, it's one of the very crucial factor why people are getting less sleep nowadays. And very important to have a social support or confidant. Yes, now coming to the last part of the topics, we'll talk about in brief about the mental health program. So, there is this National Mental Health Program, which was launched in 1982. So the aim is basically to ensure that minimum healthcare, mental health care is available and accessible to everyone. And we need to promote the community participation for this. So what are the strategies? One of the key strategies is you integrate mental health with the PHC, with the primary healthcare. And the tertiary care institution should be provided with treatment options. And one of the very important thing is to eradicate stigma for the mentally ill patients and also to protect their rights through regulatory institutions. So we have the Central Mental Health Authority at the center, and at every state has its state mental health authority. Now let's look at the district mental health program. This has been existing since 2003 in all over the districts. So what are the components of this? Uh, the services should be provided. So most of the cases of mental disorders should be provided at the centers and counseling at the different levels of these district healthcare delivery systems. One of the key things which is required is the manpower training and development of prevention, early identification and management of mental disorder, and the IEC activities, that is the information education. So the objective mainly will be to provide sustainable basic mental health services to early detect and treat in the community itself rather than them having to come to the centers. This enables to remove the pressure of the mental hospital and also indulge in activities to reduce stigma, to create awareness, and to rehabilitate people in the community. Now, many of the districts are running this district mental health program very well. So very often you will see it's a mental health team. It will comprise a psychiatrist, a clinical psychologist, a psychiatric social worker, and a psychiatric nurse. So together they'll be running these programs. Along with mental health, they will also be dealing with cases of epilepsy. They also train all ground level workers, which are very useful because here we are targeting ground level or the community, where we are not depending on everything to finally, like so far we were discussed about referral to psychiatrists, but as you know, the resources are limited. So here we are talking about taking mental health care delivery to the doorstep, that is to the community. So that can be done through Anganwadi workers, ASHA workers, ANMs, by training them to identify basic mental illnesses, which are very common, as you all must have seen through PHQ-9. Actually, it is very easy to screen people with very common mental health disorders like depression. And if you see, things like PHQ-9 are even available in local languages, like say Hindi, Marathi, and a lot of languages they are available. Now, last but not the least, what is the role of the ART center? It is very important that the ART center should screen PLHIVs by PHQ-9. It's a very easy tool to use. As you all saw through it, some of you all even used to rate it, right? And you all were pretty right in doing it. The thing is that it's a very easy scale to use. People can fill it themselves also because it's available in local languages. What else the ART center can do? The referrals to the Department of Psychiatry, either in the nearby area or through the district mental health program. You should identify the warning signs. That is when a person sounds suicidal, expresses death wish, or talks about life after death, is when you identify warning signs. And that is where the ART center is very important because they will be really talking to you, especially the counselors. They'll be talking to you all regularly. So you all can identify the warning signs, counsel them on mental health issues. You can even monitor them when they are undergoing psychiatric treatment, provide them psychosocial support, help them in self-management skills. A very big chunk of work that has to be done is in adherence counseling, that they should remain adherent to whatever, to ART, psychiatric medications, or even the antihypertensive, whatever, to be adherent with their treatment. Try to involve their peers, try to involve the community, try to involve their supportive family members, and integrate these mental health services into your routine services. And of course, where it is required, you coordinate with the concerned hospital authorities for better care of PLHIVs. I would request all of you all to go through the PHQ-9 again. It's a very useful tool and highly recommended. It will be very useful for you all in your routine practice. So to conclude, mental health disorders are many, varied, bidirectional, and please, they do often get neglected. So they should be identified early. Why? Because their presence compromises HIV care and prevention efforts. If they are not treated, they are not addressed, they compromise the treatment outcomes, and they can cause or leave pockets for potential HIV spread, and hence we get poor quality of life. It is very important to screen for mental health issues. and integration of these mental health care in routine HIV care and prevention care programs is important. So I would like to conclude my sessions, and candidates can please ask questions.
Thank you so much, ma'am. Ma'am, right now we have two questions in the chat box and we'll give mic access to everyone shortly. The first question
Yes.
is how to differentiate delirium from delusion in a PLHIV.
Yes, that is the because especially the hypoactive won't be difficult because they are quiet and silent. The hyperactive might be difficult because they could be actually muttering, could be having active hallucination. The core one symptom to differentiate would be orientation. So a person who is having delusions will not be disoriented. They will only be have a delusion or a hallucination, whereas a person who is delirious could be feeling that they are at their home, or they might be imagining that it's day when it is night. So they'll be confused. And second important is also that the in cases of delusion, often the delusions are systematic and fixed, whereas in delirium the delusions could change. So it could be वो आके मुझे मार रहा है, then second minute they'll say तुम अच्छे हो और वो मार रहा है. So it could be fluctuating, and the nature of the hallucination. In case of delusion or psychotic disorders, very often you see auditory hallucinations, but in case of delirium, typically you will see tactile or more predominantly visual hallucination or illusions also.
Thank
Yes,
you, ma'am.
and the second question?
Yeah, in your opinion, is PHQ-9 sufficient enough to assess a PLHIV?
For depression, yes, but it may not be useful for, say, cases like hand, or it may not really catch up anxiety disorders because only very few of the questions relate to anxiety. So yes, but as I told in the beginning, the most disabling amongst the psychiatric disorders is depression. The most common is anxiety and depressive disorders. So PHQ-9 would not be the only scale to assess PLHIV, but yes, it is the most important scale, because most of the cases which can be treated and can be identified at the center level is by PHQ, and it is a very sensitive and a specific scale.
Thank you, ma'am. Kiran sir, can we give access to everyone now? Mic access. Participants can now unmute and ask questions. Bhagyalakshmi ma'am, would you like to come in? You have raised your hand. Any questions from the participants? Please feel free to unmute and ask questions. You can also post your questions in the chat box. Ma'am, I don't think there are any questions. Thank you so much for facilitating this important session.
The pleasure is mine. Thank you for inviting me.
Thank you, ma'am. Thank you to all the participants for patient listening. Pallavi ma'am, would you like to come in? Any questions from the
Yeah,
participants? Yes, ma'am.
yes, ma'am. Ma'am, actually, I'm a counselor from Karnataka.
Hmm.
I actually joined very late, but my question is like the questionnaire brought regarding this mental these issues, no, ma'am, like
Yes.
to rate the depression. So that actually I used to do it for new cases because it is in the checklist. So I used to do this for the new cases, but almost all new cases are like they are in like their number is like high. So is it useful for the new cases or like for the regular cases, ma'am?
No, it
Like
is useful even for the even for the new cases, because as you're saying, the new cases have just got the diagnosis. So it's
yes,
very likely that the score will come higher. See, this
yes,
is the PHQ-9. Yes, the score will come high. But
yes, ma'am.
that's why it is said that you are supposed to do it every 6 monthly. Because most of the disorders, the psychiatric disorders, I have explained before in all the slides, the prevalence in PLHIVs is much higher, tenfold than in the general population. And it gradually develops over time, not just the first diagnosis. Very often people within 3 months get adjusted to the diagnosis. But because of the illness itself, the ART, the ongoing social issues, the financial issues, the stigma, everything causes to a person to be extremely susceptible to developing mental health disorders.
Yes.
And that's
Yes.
why they should be assessed every 6 months.
Every 6 months. Because like why I asked ma'am, because all the new cases, most of them will be having a suicidal tendency. Like obviously they say we would like to they will be having this a suicidal tendency, no ma'am. Like
Yes,
that
yes,
score will be coming high. So
yes, yes.
in the first initial days, we are not supposed to we have to judge and we have to send them, no ma'am. Like every
You can
6 months
judge
we
and
have to.
send, and of course, you will be also counseling them as a
Yes.
part only, because you all must be seeing this, because hearing this diagnosis very
Yes.
often, and the public perception about the illness, people
Yes.
often come through a lot of shock, and
Yes,
they get
ma'am.
very upset.
Yes,
So
ma'am.
the supportive role will be there any which ways.
Hmm.
Correct. And
Okay.
as they will
Yes.
follow up, then you all will start on the starting of ART, it has to be started.
Hmm.
So the first
Okay.
you diagnosed, and in some days you would start ART, right? So when you're
Yes, ma'am.
starting the ART, that is the time you should apply it.
Okay. Yes, ma'am.
And if you're getting a
Okay.
high scores, yes, you can repeat later, not just 6 months later.
Yes. Okay. Yes, ma'am. Means second sittings or third sittings again we have to
Yes,
repeat.
yes, yes,
Yes, ma'am. Yes, ma'am. Okay, ma'am. Thank you so much.
yes. Thank you,
Yes, thank
everyone.
you.
Yes.
J.K. Kurada, sir, would you like to come in?
Namaste, ma'am.
Yes, ma'am.
Namaste,
Yes,
ma'am.
sir.
Thanks for the enlightening session. Ma'am, I would like to check with you what is the threshold score to actually start the medication component of depression treatment, ma'am?
Yes. So, what we are saying is 0 to 4 depression is unlikely, 8 to 9 is mild, where we can maybe not wait, not give medication. The cutoff score which you can consider is 10. From
Okay.
10
And
to 10 to 14 is moderate, but 15
right,
onwards is moderate to severe. So for 15 to 27, it is recommended that you start on antidepressant.
right. So just like TB, once initiated, we at least give the regime for like 6 months. So for these cases, assuming that the threshold is 10 or 15 kind of threshold, what is the minimum duration that these antidepressants should be given, ma'am?
Yeah, minimum should be 6 months. Around 6 to 9 is what is recommended. And I would also like to add that, since 15 is the cutoff, okay, I would also like to add the core word that you should remember is pervasive. See, a lot of
Okay.
people could have a reaction to an issue. It could be anything, the first time diagnosis, as previous madam said, or it could be some other issue in their life, or could be a financial issue, or some worsening in the illness. So generally, if a person is having that adjusting problem or having depressive symptoms which are pervasive, lasting most part of the day, or feeling at least sad most part of the day, then you should consider an antidepressant. But if
That
it is a
helps me.
fleeting one, if it is fleeting, you can wait and see with supportive therapy.
Sure. Ma'am, for forest screening for tuberculosis, we consider even one abnormal reading eligible for testing and confirmation. For the administration of this PHQ elaborate questionnaire, is a single episode of scoring enough, or would you recommend a serial repetitive score for consistency and then taking clinical judgment, ma'am?
Yes, see, what we can do is the first core, when we apply the PHQ 9, we apply on that basic first two questions which are core. That is feeling low, that is sadness of mood, and decreased interest in previously pleasurable activities are the core questions. If those core questions have had a yes, okay, and if the person is having moderate, like 15 and above scores, anyways, you can take help of a psychiatrist, which will be available even at the district level.
Understood,
Okay.
ma'am.
But as she said before that, sometimes it could be reactionary, in which case you could apply, say, on your next visit.
Okay. Okay.
So you could
Makes
have
sense.
two different
So,
scores.
certainly, ma'am. Ma'am, how difficult is it for the patient to process an additional comorbidity? I'm already down with the new diagnosis of HIV, etc. And you're trying to follow the protocol by mentioning that, see, I have depression, I need to go through this cycle to actually get better. So, from the patient perspective, how difficult is it to process that information and actually act on it, ma'am? The reason why I asked that is I have been to many difficult to retrieve LFU patients at their homes, and their mental state is so restless. Either they are too anxious or too sad or apathetic, that they dropped off psychiatric medication care as well as ART medication care. In such instances, which supersedes urgent initiation, ma'am? Is it the psychiatric care or is it the depression? And how long will it take to actually realize that, okay, medications are working and let me also get onto the ART care?
See, that's where what I was talking about. The biggest challenge is this, when they have a dual diagnosis. And in case of substance, so it gets worse when they have a triple diagnosis. Like, like the people you are saying, that the one you had to go home were the ones who felt so hopeless because they were so depressed and they felt hopeless that they didn't even want to take the ART. Okay, it will be difficult to say which one is more important, the depression or the HIV, because both are afflicting the same person. Both require the equal quality of care. But the reason I'm focusing so much on depression is because depression often causes hopelessness, and hopelessness causes that lack of belief that, that ART will help. And that's where the HIV treatment gets worse. And so
how
we
long
need
do they
to
usually take,
even
ma'am,
treat.
to respond, to feel better?
See, yes. Antidepressants normally take around 2 to 4 weeks to act. If suppose they are not improving, you can refer to a psychiatrist. The psychiatrist will, of course, calibrate the medications. Most of the patients, 50% at least, improve within the first 2 to 3 months. Of course, they do not become totally non-depressed, but at least to a functional level where they could be treatment compliant and could have a reasonable quality of life.
That helps me. Thank you so much for your patient insights.
Yeah, thank you.
Thank you so much, sir. Any more questions? Please feel free to unmute. Ma'am, we have a question in the chat box.
Yes. Sorry, I didn't see it. Can
I'll,
you please read out?
I'll read it out, ma'am. Generally, anxiety disorder is normally found in the PLHIV and causes problems in adherence and suppression in viral load. Can a benzodiazepine be added normally, or should we consult a psychiatrist for this? Reference is PHQ 529.
Yes. So in this case, PHQ level you're talking, no? 5 to 9 is the PHQ 9.
Score. It must be, yeah.
So predominantly the person is anxious, right? So as we discussed, it's very important in case of anxiety disorders that counseling often helps. And yes, if medications are required in cases, you can start with a benzodiazepine even at the ART center level, because it is invariably understood that the benzodiazepine has to be given for a shorter duration. That is, it is recommended it should be given for the first 2 to 3 weeks only. So yes, short-acting benzodiazepines as alprazolam or lorazepam, or a long-acting benzodiazepine like a clonazepam can be given, but not more than 2 to 3 weeks. If you feel despite this the person is feeling anxious, you can start SSRIs which are pretty safe, like sertraline, the fluoxetine, or if the anxiety is persistent, you can refer to a psychiatrist. But for milder acting, like, shorter acting, like say a 1 or 2 week anxiety can be treated at the ART level.
Thank you, ma'am.
Ma'am, sleeplessness is a side effects of TLD now. So how can we differentiate that depression and the side effects of the TLD?
Yes. See, now again, if it's a side effect of TLD, the person will have only, say, problems in sleep. If you go to the previous slide, I don't know if it is seen, the depression symptoms. Okay. Then now the depression symptoms are 2 types, the affective and the somatic. The somatic ones are the ones which can come in HIV itself or its side effects, like say loss of weight, sleep disturbances, agitation, fatigue, poor concentration. But the core of depression is the mood symptom. So feeling low, feeling not interested in things they enjoyed before, or feeling guilty, feeling helpless, hopeless, worthless, feeling like it's better if they were dead. Now, these are classical depression. So person who is presenting only with insomnia, you can think more of...
Yes, I'm getting it, ma'am. I'll take a screenshot of it and I will...
Yes.
Pallavi, ma'am, we'll be sharing the recorded link as well as the PPT.
Yes, ma'am. I used to see. Yeah, yes, ma'am. Sure. Thank you, ma'am.
Thank you. Any more questions? We can remain here for another 2 minutes. Please feel free to put your questions in the chat box. Kurada sir, any questions from your end?
Thanks, ma'am. Ma'am, does passive ideation call for evaluation? Is it as harmful as the active ideation? Without a plan and with a plan? I mean to ask that.
Yes, but evaluation is necessary because even if a person, of course, it is less when we talk in terms of severity, an active suicidal thought or a plan, an intent, that is much more severe. Okay, but passive death wish itself is a marker that something is wrong and the person could be depressed. Like when a person feels life is not worth living, then you need to rule out the other symptoms of depression if they are there. And if they are there, to a milder intensity, a supportive plan or a psychotherapy or the center counselor can come into the picture and help the person. We can involve a loved one or some peer or a support group. If it is higher, then of course, then we need to look in terms of treatment.
Okay, ma'am. Violence is a marker of mania, domestic
Both
violence, PLHIV.
now again mixed. It could more than mania. I would say it is much more common in substance. Substance is the highest cause of domestic violence. And last but not the least, of course, depression also. I mean, as we said, most of the depressed might be feeling low, but a small subset also has the conduct issues. So they would be highly irritable and, could indulge in violence. And of course, mania, yes. And as we see worldwide, domestic violence could be without any psychiatric disorder also.
Right.
Yeah, but much more common substance, yes.
Understood. Ma'am, if I'm a caregiver, is it ethical to actually initiate this psychiatric medication in a family member who is diagnosed with a mental health disorder? Especially if if I can react violently, do you think that I'm mad, I'm in denial, and that kind of a patient? You have a loved one, PLHIV partner, but the primary partner is of a different mentality that he doesn't process that information or understand it. So in such a case, can a wife give medication dissolved in something? Is that even possible or ethical?
Ethical, it's a very tricky issue. In fact, what you spoke about is one of the most debatable topics in psychiatry. We talk about it as the surreptitious practice of giving medication. It's very often seen in our psychiatric patients where insight is not there, when they don't feel they have an illness, when they don't feel their behavior is a problem. And in this case, they refuse for any treatment. But it's the loved one, the caregiver, who knows that there is something wrong. This is not the way the person was. And this is the way which is the changes have come because of some illness. And yes, the caregiver wants to treat the person, but the person refuses to do so. Surreptitious practice can be used again, but I'll say it won't be ethical. It could be used in extreme circumstances when it is necessary, emergency situation. But generally, as psychiatrists, what we have seen is that it finally helps to talk with the person and try to get that person on the same page. So sometimes it could be, the wife is trying to tell him, but he's not listening. So if she can involve somebody, like some family member to whom he might listen to, or say some community group, that community leader who might talk some sense to him that, dekh lo, ye aisa ho raha hai. She can try to take help of someone to talk to him. And of course, nothing works, then for the better, she can give medications, but that can't happen forever. Finally, she'll have to take that person on board. It is most useful when we try to convince the other person, the patient.
Makes sense, ma'am. Ma'am, before I sign off, like one last question. Is there any absolute contraindication when we are clubbing mental health care or medications with PLHIV?
No, there is no absolute contraindication. In fact, as you see, both are so common together. And if you see that, not just that, in general, we have seen in psychiatric practice that people who attempt or commit suicide have very often visited any healthcare provider in the last 1 week. So it is even more necessary that we as psychiatrists, we propagate to all healthcare providers that they should be vigilant about mental health.
Thank you so much.
Any more questions? Ma'am, I don't think there are any questions. Thank you once again for facilitating this very important session. Thank you to all the participants for patient listening. We'll conclude the session now. Thank you.
Thank you, everyone.